If I told you that the key to curing severe chronic pelvic pain was hidden in a roughly 1.6 centimeter cluster of tissue, a cluster that half the medical community used to treat as an urban myth, you might think I was pulling your leg.
Oh, absolutely. I mean, for decades, if you read about female sexual anatomy in, like, a magazine, the language was just incredibly vague.
Right, it was always described as this, mystery button hidden somewhere in the dark.
Exactly. But today, for this deep dive, we are stripping away all that folklore. We're looking at the actual, undeniable GPS coordinates of the Grafenberg zone, which most people just know as the G-spot.
And welcome to the deep dive, by the way. Our mission today is just, well, it's fascinating. We are pulling from a really diverse stack of highly technical sources.
Yeah, we've got a clinical case report on treating vulvovaginal atrophy, plus dense surgical texts like female genital aesthetic surgery.
Right, and we're using those to map out exactly where this anatomical target actually is. We're going to unpack the precise landmarks doctors use.
Specifically, we'll look at the distance from the urethral meatus and why some sources say 1.5 centimeters, while others cite a 2 to 3 centimeter range.
And we're also going to get into the genuinely surprising medical benefits of injecting this exact coordinate. Because,
Yeah.
when you look at the clinical data, surgeons clearly do not operate on myths.
No, they don't. I mean, if a doctor is going to inject a highly sensitive area with a dermal filler or, a regenerative hydrogel, they need a scientifically verifiable location.
They need a real target.
Right. But before we can even measure the distance to that target, we kind of have to establish what the target actually is.
But it's not just a spot, right?
Exactly. The term G-spot is fundamentally a misnomer, and that causes, well, a lot of the confusion you see in popular media. It implies a single tiny dot.
Like an X on a treasure map.
Right, but in the clinical world, it's understood as an anatomical functional unit. It's a highly dynamic complex of different tissues that are all working together.
So it's less like a single planet and more like an entire solar system of tissues.
That is a highly accurate way to visualize it, yeah. Depending on the specific surgical text you look at, this system is described in a few overlapping ways.
Like what?
Well, many texts refer to it as the urethral sponge.
The urethral sponge.
Yeah, which is
Yeah.
this robust cushion of erectile tissue. It's really rich with blood vessels, and it entirely surrounds the urethra.
Okay, that makes sense.
But then other medical sources describe the functional core of this area as the female prostate gland. Anatomically, those are known as Skene's glands.
See, the idea of a female prostate usually stops people right in their tracks. I mean, we're taught biology in such heavily gendered binary terms.
No, for sure.
So discovering shared hardware feels a bit like a glitch in the matrix,
It does, but the underlying blueprints for human anatomy are incredibly unified. The male prostate and the female Skene's glands are, they're embryologically homologous.
Meaning they start from the exact same place.
Exactly. In early fetal development, they originate from the exact same tissue structures before they differentiate based on hormones. They even produce similar enzymatic secretions.
That is wild.
It really is. And the modern clinical mapping of this specific region actually traces way back to 1950.
Right, Dr. Ernst Grafenberg.
Yep, a German gynecologist. He formally documented a distinct erogenous zone along the anterior or the front vaginal wall.
And he noted that it sat right along the course of the urethra.
He did, and he saw that it actually engorges or, swells with blood during stimulation.
Hence the G in G-spot, named after Grafenberg.
Precisely.
But okay, if Grafenberg mapped this back in 1950, it is honestly baffling how vague the directions to find it became in the decades that followed.
Oh, it really is.
I mean, if you look at general health articles, the measurements given to the public are always so relative. They tell you to look like 2 to 3 inches, which is roughly 5 to 8 centimeters up the front vaginal wall.
Or they might say 4 to 5 centimeters inside the opening.
Right. It is the anatomical equivalent of giving someone directions by saying, just drive down the road and turn left at the big tree.
Yeah, that's exactly it. It completely lacks any sort of fixed, unmoving starting point.
Because the opening changes.
Yes, the vaginal opening, or introitus, is highly elastic tissue. I mean, it stretches, it changes shape, it responds to the environment.
Right.
So if you measure from a flexible starting line, your end destination is going to change every single time.
And if you are a pelvic surgeon holding a needle, turn left at the big tree is basically a recipe for a malpractice suit.
Completely. These doctors are navigating a dense, highly sensitive network of nerves, Vestibular glands, delicate erectile tissue.
Right, so a vague estimate just doesn't cut it.
Not at all. A vague estimate from a flexible opening doesn't give you a clinical target. Clinicians have to rely on a completely different navigational system.
So what do they use instead?
They use an internal, fixed anatomical landmark, and that landmark is the urethral meatus.
The urethral meatus, that's the external opening of the urethra, right? Where urine exits the body.
Exactly. And because it's tethered to the more rigid structures of the urinary tract, it doesn't dramatically shift or stretch the way the vaginal opening does.
Okay, I see.
So for a surgeon trying to locate the G-spot complex, the urethral meatus essentially serves as true north.
True north. Okay, let's get into the actual numbers from our sources then, because they get incredibly granular once they establish that true north.
They really do. The clinical literature leans heavily on a very prominent cadaveric dissection study. It was conducted by an anatomist named Ostrozensky.
Right, I remember seeing that one in the stack.
Yeah, and in this specific study of fresh cadavers, he didn't just find a vague, spongy area. He identified the G-spot as a distinct, bluish, grape-like sac.
Grape-like sac. Made of what exactly?
Made of fibroconnective and erectile tissue, and he mapped its location to exactly 16.5 millimeters, so about 1.6 centimeters from the upper part of the urethral meatus.
16.5 millimeter. I mean, he essentially gave it a postal code.
He really did, and he mapped its orientation, too. This distinct sac sits at a 35-degree angle to the lateral border of the urethra.
Wow, that is specific.
Yeah, and the lower pole of the structure is just 3 millimeters away from the urethra itself, while the upper pole extends out to 15 millimeters. It just runs parallel to the urethral canal.
Okay, I have to push back on this exactness for a second, though.
Sure.
Because if Ostrozensky found this grape-like sac at exactly 1.6 centimeters, the other medical texts in our stack seem to contradict him.
Well, contradict is a strong word, but they do differ.
Right, because the Times Surgical Textbook notes that this area is typically found 1 to 2.5 centimeters, or even in the 2 to 3 centimeter range, inside on the anterior vaginal wall near the bladder neck.
That's right.
And then, on top of that, we have this recent clinical case report on treating vaginal atrophy. And that one states they placed their targeted microinjections roughly 1.5 centimeters from the urethral meatus.
Yeah, the numbers bounce around a bit.
So we have a highly detailed cadaver study planting a flag at 16.5 millimeters, and then textbooks citing a much broader 2 to 3 centimeter target zone.
Exactly.
Are these doctors aiming at different things, or does the human body just, refuse to conform to a single number?
It's definitely the latter. The human body is highly dynamic, and you are touching on the core difference between dissecting a static cadaver and treating a living, breathing patient.
Yeah, okay. That makes sense.
Remember, we defined this earlier as an anatomical functional unit. This complex, the Skene's glands, the urethral sponge, the surrounding neurovascular bundles, it spans a regional zone.
So it's not just one tiny dot.
Right. And individual anatomy varies wildly. The distance between the urethral meatus and the epicenter of that nerve cluster might naturally sit at 1.5 centimeters in one patient and maybe closer to 3 centimeters in another.
Okay, so it's a bit like facial proportions. Like, no two people have the exact same distance between the bridge of their nose and their upper lip, even though the structural map is the same.
That is a perfect analogy. And furthermore, the physical state of the tissue completely alters the topography.
What do you mean by physical state?
Well, hormonal fluctuations, age, childbirth, and especially sexual arousal, they all cause massive structural shifts.
Right, because of the blood flow.
Exactly. During arousal, that urethral sponge we talked about engorges with blood. It expands outward and literally changes the entire landscape of the anterior vaginal wall.
Wow.
So while the 1.5 to 3 centimeter mark from the urethral meatus is the universally recognized clinical coordinate, the exact epicenter of sensitivity within that range shifts.
But the meatus gives them a steady starting line.
Yes. The urethral meatus simply gives the surgeon the fixed anchor point to measure from, allowing them to locate that 2 to 3 centimeter zone, regardless of how much the surrounding tissue is stretching or swelling at that moment.
Okay, the map makes total sense now. We have our true north at the meatus, and we are targeting that roughly 1.5 to 3 centimeter zone. So now that we know where the target is, let's look at what doctors are actually doing when they find it.
Yeah.
The cosmetic sources refer to the augmentation procedure as the G-shot.
Yes, the G-shot.
What are the actual mechanics of this, and what materials are they using to augment the tissue?
Well, the primary mechanical goal of G-spot amplification is to physically plump up this tissue complex.
Okay, plump it up.
By injecting a bulking agent into that precise 1.5 to 3 centimeter landmark, the surgeon forces the underlying structures caudally.
Caudally. Break that down for us.
In anatomical terms, caudally here means pushing the tissue downward and outward toward the vaginal lumen.
And the lumen is just the open space of the vaginal canal, right?
Exactly. The underlying theory is based on very simple friction mechanics.
How so?
If this specific zone of erectile tissue and nerve endings protrudes more prominently into the canal, it basically experiences much more direct physical contact and stimulation.
Okay, my mind immediately jumps to facial fillers here. If they're just trying to plump up a specific zone of tissue, are they essentially using, like, lip filler on the pelvic floor?
In many ways, yeah. The most widely used material in modern practice is hyaluronic acid, or HA, which is the exact same substance dominating the facial filler market today.
That's fascinating.
Yeah, HA is a naturally occurring glycosaminoglycan.
Hold on, glycosaminoglycan. That is a massive mouthful of chemistry. Break that down for us. What does it actually do when it gets injected?
Fair enough. Think of it as a microscopic molecular sponge. It's a complex sugar molecule found naturally throughout your body's connective tissues, skin, and cartilage.
Okay, a sponge.
And its primary superpower is its ability to bind to water molecules. It can hold up to 1,000 times its weight in water.
Wow, 1,000 times.
Yeah. So when a surgeon injects HA into the mucosal tissue of the vaginal wall, it doesn't just take up physical space, it actively draws in surrounding moisture.
Creating, like, a deeply hydrated, bouncy cushion.
Exactly, though our sources also mention alternative materials. Some surgeons prefer autologous fat, which involves a mini liposuction to harvest fat from the patient's own thighs or knees.
And then they just re-inject it.
Yep, they purify that fat and re-inject it. There are also references to human-engineered collagen being used as a bulking agent.
Okay, so the material makes sense.
Yeah.
But the depth of the injection seems just as critical as finding that 2 to 3 centimeter distance from the meatus.
Oh, absolutely. Depth is crucial.
Because one of the texts explicitly mentions that the target tissue sits about 1 centimeter deep into the vaginal wall.
Right.
But, I mean, injecting a filler 1 centimeter deep into a zone that is packed with dense nerve endings, delicate glands, and erectile tissue, that seems incredibly risky.
It is a major concern.
How do they shove a needle into a sensory hotspot without causing permanent nerve damage or, destroying the very sensation they are trying to enhance?
That risk of nerve damage is actually a huge point of contention in the field. It has sparked a really fascinating debate in the surgical community about the safest route of entry.
Oh, really? Which source covers that?
This is heavily detailed in the plastic surgery, key source from our stack. The traditional, universally taught method is transvaginal.
Meaning they just go straight in?
Exactly. The surgeon goes directly through the anterior vaginal wall, passing the needle right through the sensitive mucosa to deposit the filler into that 1 centimeter deep space.
The straightest line between 2 points. It seems like the most logical approach, right?
It's the most direct, sure. But anatomical researchers argue it might be fundamentally flawed.
Why is that?
They point out that the bulk of the G-spot tissues actually reside within the urethrovaginal septum.
The urethrovaginal septum, that's the dividing wall between the two.
Right, the dividing wall of tissue between the urethra and the vagina. And the critical nerve clusters and glands are situated much closer to the urethral side of that wall than the vaginal side.
Oh, wow. Okay.
So by piercing through the vaginal wall, you are driving a needle directly through the sensory surface.
So if the traditional front door approach risks damaging the sensory surface, how do they get the filler into the wall without doing that?
Well, they advocate for a transurethral approach instead.
A transurethral.
Yeah. Instead of going through the vagina, they utilize a specialized viscous fluid injection set and go inside the urethra itself.
Okay, that sounds intense.
They navigate down the urinary canal and inject 1.5 to 2.5 milliliters of a permanent bulking agent. A product called macroplastique is mentioned just under the muscularis.
The muscularis being the muscle layer of the urethra.
Correct.
Wait, so they are going in through the urinary tract to deposit the filler behind the sensory tissue.
Exactly. They are placing the filler behind the entire G-spot complex. As that pocket of fluid takes up space in the wall of the urethra, it basically acts like a physical wedge.
Oh, I see.
It pushes the entire urethrovaginal septum, including all those sensitive nerves and erectile tissues, outward into the vagina.
Wow. They are essentially sliding the pillow behind the sensory tissue to push it forward.
That's a great way to put it, yeah.
That completely bypasses the need to poke needles into the sensitive vaginal surface. It achieves the exact same mechanical goal of making the tissue protrude, but eliminates the risk of scarring the delicate mucosa.
Exactly.
I mean, that is just a brilliantly engineered solution to a really delicate plumbing problem.
It really is. It highlights exactly how critical precise anatomical mapping is. But this level of medical engineering bridges us into what is arguably the most transformative aspect of the source material.
Right, because up to this point, we've mostly discussed G-spot amplification as a cosmetic or sexual enhancement procedure.
Yeah, the G-shot marketed for better physical intimacy.
But clinicians are taking this exact same anatomical coordinate, that 1.5 to 3 centimeter mark from the urethral meatus, and using it to treat debilitating medical conditions.
Yes. The line between cosmetic enhancement and functional regenerative medicine is completely dissolving here.
And this is where the science stops being about aesthetics, starts being about quality of life. Let's look at the clinical case report we have.
This one is really compelling. It focuses on a 48-year-old perimenopausal woman.
Right, and she was suffering from severe vulvovaginal atrophy.
Yes. Her tissue had basically lost its structural integrity, elasticity, and hydration due to declining estrogen levels.
And she was dealing with dyspareunia, which is the clinical term for significantly painful intercourse.
That and anhedonia, which is a complete loss of sexual pleasure. And the sad thing is, for millions of women, this kind of severe chronic pain is routinely dismissed by the medical establishment.
Yeah, they're just told it's a normal, unfortunate part of aging that you have to learn to live with.
It's a profoundly common and heavily undertreated reality. Standard protocols often involve just prescribing topical hormonal therapies.
But those don't work for everyone.
Right. This patient might not have been a candidate, or perhaps they just hadn't worked for her. So the clinicians utilized a highly targeted, multi-layer approach.
Okay, a multi-layer approach.
Instead of standard HA filler, they used a specialized regenerative hydrogel. The text identifies it as a PEG-D cross-linked hyaluronic acid enriched with calcium hydroxyapatite.
Okay, stop right there. PEG-D cross-linked hyaluronic acid enriched with calcium hydroxyapatite.
I know, it's a lot.
That sounds like the materials list for a synthetic aerospace component. What does that actually mean for human tissue?
Let's strip away the chemistry jargon. Normal hyaluronic acid dissolves relatively quickly in the body. PEG-D is simply a chemical linking agent.
Like a glue.
Sort of. It weaves the HA molecules together into a durable three-dimensional mesh, so it lasts much longer as a physical cushion.
Okay, got it.
But the real magic, however, is the calcium hydroxyapatite. It is not just a space filler, it is a biostimulator.
A biostimulator, meaning it actively interacts with the biology of the surrounding cells.
Exactly. When injected, the microscopic calcium particles actually act as an irritant, but in the best possible way.
How can an irritant be good?
They signal the local fibroblasts, which are basically the biological factories in your tissue that build structure, to start producing massive amounts of new native collagen.
Oh, wow.
So while the HA provides immediate hydration and cushioning, the calcium hydroxyapatite is actively planting the seeds for long-term tissue regeneration.
So they have this incredibly durable collagen-farming hydrogel. How do they actually apply it to the patient?
They map out the exact coordinates we have been discussing all episode. Using tiny needles, they place small, 0.1 milliliter microinjections precisely into that G-spot zone.
Pinpointed at approximately 1.5 centimeters from the urethral meatus, like we talked about earlier.
Exactly, right into the lower third of the anterior vaginal wall. They also combine this with other targeted injections in the vestibule area.
Right.
The hydrogel even includes specific amino acids like glycine and proline. Those act as the raw building blocks for the new collagen the body is about to produce.
The results recorded in this case report are staggering. I mean, this wasn't just a subjective feeling of improvement.
No, the clinicians used objective, validated medical scales to track her recovery. They utilized the Veith scale.
The Veith scale, what does that measure?
It's a clinical tool designed to measure specific tissue health parameters. They looked for things like petechiae, which is microscopic bleeding under the surface of the tissue, alongside tissue pallor, thinning, and severe dryness.
And what happened after the injections?
Following the targeted injections, all of those issues completely resolved. The tissue transformed from being paper-thin and fragile to deeply hydrated, vascular, and resilient.
That is incredible. But the functional leap in her quality of life is the real headline for me. They tracked her sexual function using a validated screening tool called the FSI-6, right?
Yes, they did. And her total score jumped from a highly dysfunctional baseline of just 6.0 all the way up to a healthy normal score of 24.0.
And that was in just 6 weeks.
Just 6 weeks.
I mean, it sounds like the clinicians are treating this tissue less like, cosmetic lip filler meant just for aesthetics, and much more like injecting biological mortar into a crumbling brick wall.
That's exactly what they are doing.
They are restoring the absolute structural integrity of the house.
The hyaluronic acid hydrogel literally acts as a physical scaffold. By restoring the extracellular matrix, it draws in that massive hydration and provides essential mechanical protection for the highly sensitive anatomical structures we mapped earlier.
So by plumping that specific 1.5 to 3 centimeter coordinate, they are no longer just increasing friction for pleasure.
Right.
They are physically cushioning fragile, exposed nerves and glands that were previously causing the patient severe daily pain.
Exactly. It's life-changing for the patient.
Let's step back and look at the sheer distance we have covered in mapping this out today.
We've covered a lot of ground.
We really have. We started with the G-spot, a concept that popular culture treats as a vague, culturally debated myth, a mystery button with no real address.
Yeah.
But through these surgical and clinical sources, we have pinned it down to an exact, undeniable clinical reality.
It is a dynamic complex of glands, nerves, and erectile tissue, and surgeons can reliably locate it in a zone typically 1.5 to 3 centimeters from the urethral meatus.
A verifiable coordinate that can be mapped, measured, augmented, and functionally restored. We've seen how doctors use the urethral meatus as a true north anchor, allowing them to navigate dynamic living anatomy.
Right.
We explored the mechanical brilliance of injecting behind the sensory tissue via the urethra to avoid nerve damage. And most importantly, we saw how mapping this exact coordinate allows doctors to use advanced collagen-stimulating hydrogels to functionally heal atrophied tissue.
It really is giving patients their quality of life back.
It is.
And, the implications of this precise anatomical mapping extend far beyond just a single case report. The authors of these clinical papers pose a really fascinating, almost provocative question based on this data.
Oh, what do they ask?
They point out that this region is clearly linked to Skene's glands, acting embryologically and functionally as a female prostate, right?
Right.
Given the reality of this complex, highly sensitive structure sitting just 2 to 3 centimeters inside the anatomy, the authors ask, how much of historical female sexual dysfunction conditions dismissed for decades as being entirely psychological was actually just a failure of modern medicine to properly map, understand, and physically treat this specific zone?
Wow. That is a heavy question to ponder,
It is.
but an essential one. When the medical establishment either cannot or will not see the exact coordinates of the anatomy, it's the patients who suffer the consequences of being told their pain or their lack of sensation simply isn't real.
Exactly.
It proves that demanding precise clinical understanding is the absolute first step toward actual healing. Thank you for joining us on this exploration of the data. Keep exploring the world around you. Keep looking for those exact coordinates in your own understanding. And always keep questioning the science behind everyday wellness.